on the Commission of Veterans Affairs, Board of Pharmacy, and Board of Nursing. Do I have any committee recs? Do I have any committee recs? Representative Ballard.
Stop chewing my gum, too. Thank you, Mr. Chairman. For FY 2022 and FY 2023, would like to add $145,000, all from the State General Fund, to the Board of Pharmacy for KTRACS system funding for FY 22 and FY 24. Delete the transfers of $75,000 from the Board of Healing Arts and $70,000 from the Board of Nursing to the Board of Pharmacy for FY 2022 and FY 23.
Very good. I have a motion. Do I have a second? Second by Representative Kincannon. Discussion? Basically, committee, what this does is we have been funding KTRACS through fees from this year. It's those two agencies there, the Board of Healing Arts and the nurses. And I believe that we shouldn't sweep fees, quite frankly. And they've been very voluntary. As a matter of fact, one year, I think it was $200,000 or $300,000 a couple of years ago. But, you know, when these folks send in their fees as a nurse or as a doctor or something like that, they don't say on there and spend it for anything else you can spend it for. And so that's what that is. So anyway, all in favor, say aye. Opposed, same sign. Motion carries. Very good. Any further committee recs? Representative Lynn.
Thank you, Mr. Chair. The Budget Committee recommends that the Kansas Commission on Veterans Affairs Office submit a report to the House Social Services Budget Committee by omnibus, detailing plans for current unused beds and the projected need for future bed space.
Do I have a second? Second by Representative Ballard. Discussion. Committee, just a little background on that. There is a proposal for a new veterans home in Northeast Kansas, which I have no problem with. But I also think that at that same time, with the kind of vacancy rates that we have from the agency, Kansas Veterans Home, which is Winfield, right now has 145 total beds available. And a soldier, oh, no, let me state this back here. I have it back here. Let me state this correctly. I'm not. Okay, they have 145 beds available, and the current census is 92. And that's at the Veterans Home in Winfield. And at the Dodge City Home, they have total beds of 171, and the current census is 72. So I think we have to address that in all fairness to building this new home, that's going to continue to be an issue until it's addressed. So with that, further discussion? Representative Ruiz.
Thank you, Mr. Chair. I'm hoping that we would see a different bed usage in the Northeast, and this is part of why, you know, we're asking for that. But I understand what you're saying. You know, that I know we have to look at the current best bed usage right now, and I really hope that we can turn that around when we get a nursing home in the Northeast.
Sure. And what I imagine to come out of this is something like maybe they'll have to close a unit out there. I don't know, but I just know that we have to address these empty beds that we have And the other deal, before we can move forward and address the Northeast Kansas home. So further discussion. Representative Helmer.
Yes, I'll put in a note on that. I've been out to the Winfield facility many, many times, and we have a really nice facility out there. We have one complete building that's totally empty and ready for refurbishment. And the Veterans Home in Winfield is lovely. And amazingly and sadly, we have lost a lot of veterans. I do therapy with Blue when I can. The pandemic has kind of shut us down. Blue's my therapy dog. And it's pretty much shut us down from doing therapy just on a limited basis. But there's not very many living veterans left out there. So that's led to most of the beds being empty. But it's a very lovely place and a beautiful cemetery outside. It's absolutely stunning, and the upkeep is beautiful. Thank you.
I believe I forwarded you on this information, and here's some of the documentation that we can pass around, and you can take a quick look. There are multiple ways that it's figured about their census and future census and stuff like that. And I will tell you on another personal note, much like Representative Helmer, my father passed away last March, and he had been in the Winfield Veterans Home for 5 years. And so I was down there, monthly. And it was wonderful. One time I went there and they were having the KDAD's inspection. Yeah, and so I visited with the gal from KDAD's, and they were having their monthly inspection from KDAD's there. So anyway, very nice facility. So anyway, any further discussion? Representative Ballard.
Thank you, Mr. Chairman. I second it because I realize it's something we have to look at. But the other thing is, remember, this is just to build that facility, and we're talking about 2 or 3 years before we actually get to that facility. So we'll have more time to visit with Greg, because we visited with him the other day about how they want to use it. And he mentioned to us, if you remember, that he had had quite a few deaths normally as well as COVID when he was here, which means that they will be able to reconfigure what they're doing, but also indicated that the need is greater on the northeast side than it is where they are. But that, I don't think that means that they won't be using Winfield. They will, but I think they just will be using it differently. And remember, for a while, they did have like a waiting list, especially if someone was coming with their families and they weren't just an individual person. And they also had like a dementia or Alzheimer's wing. And I think they will always have a need for that as well. But I think it opens it up with more people being on this end, that it will balance itself out over time. But we will have time to look at the configuration and how financially it will work out in many ways, because we know where it's needed. But I agree with you, that facility is beautiful in terms of what they have done. And at one point, they were running out of cemetery space, and then they had to configure how to do that as well. So we do have time that we can make decisions about it. But the facility is needed on this end. So I don't want you to think I was second, because I don't think it's needed. It is needed, but I think we have to plan more carefully to make it financially feasible. Thank you, Mr. Chairman.
Very good, committee. Further discussion? All in favor, say aye. Opposed, same sign. Motion carries. Committee, that conclude. Are there any further committee recommendations for the Commission on Veterans Affairs, the Board of Pharmacy, and the Board of Nursing? Seeing none, that concludes the budget recommendation portion of our agenda today, and we will now start I would make a motion to move the budgets out of committee. Have a second? Second by Representative Ballard. Discussion. Seeing none, all in favor, say aye. Opposed, same sign. Very good. Thank you, Owen. So motion carries. So we have officially done our job. You'll have to hit me upside the head there, Shirley, every once in a while. And as amended. Okay, committee. Megan, you're up. We will open the hearing for Kansas Department of Health and Environment.
I'm Megan Leopold with Legislative Research Department. I'll be presenting the budget analysis for Kansas Department of Health and Environment. One reminder is that this budget includes only the administrative, public health, and healthcare finance departments of KDHE. It excludes the environment, which is heard in a separate committee. There are also several members of agency staff that will be presenting testimony following my analysis and will be available to answer questions as well. So I'm going to start my presentation on page 17. So there's a little confusion if you're following along in the purple budget book. I believe it'll be page 17. If you have an old copy, it'll be, or no, I'm sorry, 39 in the budget book, 17 if you have an older copy. I will try to do both page numbers and be as least confusing as possible. So starting on page 17/39 is the fiscal year 2021 budget. In the top section, you'll see the changes that have been made to the approved budget for 2021. These include adjustments that were made following the budget that was passed by in the 2020 session. These include an increase of approximately $129 million. That's based on reappropriations that came from fiscal year 20 that were not spent in fiscal year 20 and were shifted to fiscal year 21. Then in the next line, you'll see that the governor allotted approximately $97 million of that. And much of that was due to the caseloads, the April caseloads. The April caseloads were not adopted by the legislature in 2020. And so the savings that came with that increased FMAP as part of that, the April caseloads is what you see there in that decrease in the allotments. There's also an increase of $13,000, and that's based on money that was swapped out from the state general fund for this with CRF money, coronavirus relief. And then finally, the last bullet is a decrease of $17.5 million. And that's a result of the proviso in Senate Bill 66 that moved that state general fund portion of Medicaid expansion into the coronavirus prevention fund. So that was lapsed from the budget as well, the approved budget. So at the bottom of that page, you'll see the agency requests. The agency requested a revised estimate of $3.6 billion, and that includes approximately $853 million SGF. This was an all funds decrease of about $470 million and an SGF increase of $22 million. And that's compared to the amount that was approved by the 2020 legislature with the adjustments I've mentioned above. On the next page, you'll see that the all funds decrease was primarily due to decreased federal fund expenditures for human services caseloads. And then this was partially offset by federal funds that came in due to COVID relief. The change in the human services caseloads, there's a significant change in the, sorry, I have to take off my mask. It's making it hard to talk and breathe. There's a pretty significant change between the federal funds in healthcare finance, and that's because while the state general fund portion of Medicaid expansion was moved to the coronavirus relief fund, the federal funds were not taken from the budget. They just simply weren't drawn down because Medicaid wasn't expanded. But it does cause a shift in those in the federal funds in the budget between the 2 years. The revised estimate for the agency includes 1,598 full-time positions, and this is an increase of 98.6 full-time positions above the number approved by the 2020 legislature. These include a variety of positions throughout the agency, including epidemiologic and information system surveillance staff, and that's in the Bureau of Public Health, laboratory staff in the Division of Environment, and then also Division of Healthcare Finance added some auditors and managed care organization analysts in the Managed Care Bureau, and also some additional research in the Medicaid Initiatives Research and Training Unit. Moving down into the categorical section, you'll see salary and wages. They saw an SGF decrease of approximately 1.5 million. This was largely due to reappropriated funds from fiscal year 2020, and then offset by increased salaries and wages for new positions. In contractual services, you'll see that there is an all funds decrease of about 11.8 million. Most of this decrease was in the healthcare finance. It was largely decreased expenditures for contracts that were associated with the state employee health plan that was moved to the Department of Administration with the ERO last year, as well as some expenditures for the KEYS system, the Kansas Eligibility Enforcement System, that had been budgeted under KDHE but were moved to different agencies. And then these were offset by increased federal funds that came in for COVID relief. In the commodities section, you'll see that there was an all funds increase of 35 million. And that increase is primarily due to increased COVID funds for testing and laboratory supplies. On the next page, there are all funds increases in capital outlay and aid to local units of government. Again, these are largely due to increased federal funds that came in for COVID relief. And then in the other assistance category, you'll see that there is a state general fund increase of 7.5 million. And this is largely due to the agency's supplemental request to fund the state match of CHIP through SGF rather than the fee fund that it had been funded through. And I'll talk more about that when I get to the supplemental section. So for fiscal year 21, the governor recommended expenditures of 3.5 billion, and that includes 727 million from the state general fund. This is an all funds decrease of 49.4 million and an SGF decrease of 125.5 million. In her recommendation, the governor deleted 111 million, and that included 99.8 million state general fund, and this was the savings that was included in the caseloads for April, and largely due to the increased FMAP, that 6.2% increase that comes with a public health emergency. There's also a deletion of 3.6 million of funds that were reappropriated from 20 into fiscal year 21. The governor did fund half of the agency's supplemental request for the Kansas Trauma Program. And there's the deletion of 20.9 million. That's all from the medical programs fee fund to remove the increase in this CHIP state share from the agency's base budget. Lastly, there's an addition of 89.9 million. And this is coronavirus relief funds that were allocated to the agency after they submitted their budget in September, but prior to when the governor created her budget. The governor recommends 1,598.7 full-time positions, which is the same number as the agency's 2021 revised estimate. On the next page, you'll see the agency's supplemental table for fiscal year 2021. Several of these supplements were items that were allotted in the governor's allotment in July. For example, mosquito surveillance, Lyme disease prevention and research were both additions made by the 2020 legislature, and then were allotted. The Kansas Trauma Program was, I believe, a supplemental last year that was allotted. I'll call your attention to the CHIP assistance supplemental. The state share of CHIP program has been going up increasingly year by year, and there's a pretty significant jump between fiscal year 20 and 21. The state match went up by approximately 11%. The agency has put in a supplemental request to fund the increased amount, which is $20.9 million from the state general fund, rather than including it in the fee fund that it's been funded through in the past. The agency describes that the fee fund just is unable to handle the amount that comes with that increased state match. In the supplementals table, you can also see the governor's addition for the human services caseloads, as well as the lapsed reappropriations in KDHE Health, as well as the $150,000 added for the state trauma program. And then moving up to page 22, which I believe in the purple notebook is page 44, you'll see the allotments table. 4 of the items on the allotments table, as I mentioned before, the Lyme disease testing, the brain injury registry were added. The primary health projects and local health departments. These were all additions made by the legislature in the 2020 session that were part of the allotments in July. There was also some savings that came with the adoption of the 2020 caseloads, the April caseloads. And you can see that in the line for the Children's Health Insurance Plan. Well, I'm sorry, the Children's Health Insurance Plan is not included in caseloads, but it is part of the FMAP savings. And then the medical assistance line at the very bottom, $90.2 million. So that concludes fiscal year 21. I'm happy to stand for any questions you might have about fiscal year 21 before I move on.
Committee questions. Representative Ballard.
I was just noticing something interesting in the 2021 supplementals on 42 about the mosquito surveillance. And as I was reading it, I don't think I ever realized that mosquito surveillance was actually all being controlled by a federal grant. And it has indicated here that it was funded solely by a federal grant. All federal funding was eliminated in Kansas in FY 2020. So that's really kind of interesting. So we have picked it up at that. But I'll just point that out because I had not really realized that. And yet, is it Lyme disease and, all those other kind of things which are very serious. Yeah.
Committee further questions. Representative Concanon.
Thank you, Mr. Chair. I am interested in the state trauma program. And so it was only, they requested 300,000. It was only funded 150,000. Do they need 300,000 to run the program? So where do the rest of their funds come from?
There's a description of the trauma program on page 43 in the purple notebook. The trauma program had been funded through, I believe, some fee funds that were funded through seatbelt fines, penalties, and forfeitures. And the program received a percentage of those, and those have been seeing a downward trend, so their funding has been decreasing. The 300,000 is what the agency felt they needed and able to continue upholding their statutory requirements for the program.
Okay, thank you.
I know this is a lot to digest at one time.
Well, I'm not, my husband sits on the trauma board. I'm not unfamiliar with it. I'm just curious as to how we expect them to fund how they were expected to fund themselves if we didn't fully fund them. Yeah. Thank you.
And I think that's something the agency could also speak to.
Representative Vaughn.
Thank you, Megan. In Children and Seniors, we just learned about the Children's Cabinet, and I noticed that the Children's Initiative Fund had a reappropriation to KDHE, and I was wondering if that was kind of the same fund and if that's consistently done, and kind of if you could speak more to that, please.
Mm-hmm. So the Children's Initiative Fund does contribute to the budget on a yearly basis. The reappropriation for this year was unique. It's not something that typically happens. And I believe it was in the hearing aid loan program, but I don't remember the details of why that was reappropriated.
Great, thank you, Mr. Chair.
And some of these questions, committee, we'll be asking KDHE up next, so they'll be able to probably give us some. Megan, I might want you to go over just a little bit about the difference in the FMAP. We have CHIPS, is it the EMAP versus the FMAP, difference in that?
Right. So there is there's an FMAP, the general FMAP, and that's where you saw the 6.2% increase. That covers the majority of Medicaid programs. So the 6.2% increase of the general FMAP is where we're seeing most of the savings. However, there is something called an enhanced FMAP that covers the CHIP program along with MCHIP and some other Medicaid programs, but the vast majority of it, the savings that have been seen with the enhanced FMAP are from the CHIP program. There are two different FMAPs, and I do have a memo. I actually have it in the other room. I'm happy to hand it out. I think you may have received it on the FMAP calculation, but it also lays out the two separate FMAPs and how they differ. Am I? Yeah, sorry. Trying to.
Very good. Committee, further questions? And again, we can ask the agency later on. Okay, seeing none, go ahead and start on 2022.
Okay. So fiscal year 22 is on page 45 in the purple notebook, 23 if you're not using that. In fiscal year 22, the agency requested $3.5 billion, and that includes $846 million from the state general fund for operating expenditures in fiscal year 22. This is an all funds decrease of $67 million and an SGF decrease of $6.3 million. The all funds decrease is primarily due to a decrease in federal funds for COVID-19 prevention and treatment. A lot of the federal funds that were brought into the state for COVID relief were budgeted for fiscal year '21. Some of them did carry over, but the majority of them did not. The SGF decrease is primarily due to the decreased expenditures for human services caseloads in the agency's budget. And this is offset by the agency's enhancement requests for aid to local health departments, as well as the increased uses of SGF money to fund CHIP. In fiscal year '22, the agency requests 1,598 full-time positions. This is the same number that they requested in fiscal year '21. In the salaries and wages category, you'll see a slight all funds increase. That's largely due to increases in employee benefits. And then the SGF increase is due to the agency's enhancement requests. On the next page, in the contractual services, there is an all funds decrease of $16.2 million. And that's largely due to the decrease in COVID relief funds. Those were generally around hospital preparedness and laboratory support, the divisions of public health. Commodities also saw a decrease of $19.1 million. Again, that was COVID relief funds that were available in '21, no longer available in '22, and that was largely for scientific supplies for testing. Capital outlays saw an all funds decrease of $6.5 million. This was decreased expenditures on COVID-19 relief funds for laboratory equipment. In the aid to local units of government, you'll see that there's an SGF increase of $2.6 million. And that's largely due to the agency's enhancement requests for local health department funding. And then finally, in other assistance, there's an all funds decrease of $23 million and an SGF decrease of $8.4 million. This is largely due to a decrease in federal funds again for COVID relief, but also a decrease in caseloads in the agency's budget. The governor recommended expenditures of $4.1 billion, and that includes $841 million SGF for fiscal year '22. This is an all funds increase of $550.6 million and an SGF decrease of $4.5 million. In the bullets below, you'll see that the governor once again added $150,000 to fund half of the agency's supplemental request for the Kansas Trauma Program. The governor deleted $12.6 million all funds, and that includes adding $10.8 million SGF for the, to fully fund the fall 2020 Human Services caseload estimates. As a note, the fall 2020 caseload estimates included the enhanced FMAP for 3 quarters of fiscal year '21, but no quarters of fiscal year '22. So the changes in the SGF there that you're seeing that increase is because that enhanced FMAP that made the federal match larger is no longer included in the budget. On the next page, page 47 or 25 if you're in the old copy, there's an addition of $596 million all funds and $19 million SGF, and that's to fund Medicaid expansion in fiscal year '22. There's a deletion of $29.1 million, all from the medical programs fee fund, and that's to remove that increased state share of CHIP from the agency's base budget. There's a deletion of $1.1 million state general funds, all from the administration program. This was part of the reduced resources package, and this SGF decrease has been offset with funds coming in from 2 separate fee funds. The governor recommended 1,598 full-time positions, and this is the same number that the agency requested in '21. In the table below, you'll see the agency's enhancement requests for fiscal year '22. Many of them are the same as the supplemental requests. There are some new ones. There's a request for disease intervention for primary and congenital syphilis transmission. There's a harm reduction advisory council supplemental request, or enhancement, I'm sorry. And And there's also a request for $2.6 million for aid to local units for local health departments. You'll also see the $29.0 million for CHIP assistance, which is the increased state match expected for fiscal year '22. And then in the table, you'll also see the governor's additions for Medicaid expansion and fall human services caseload adoption. Turning ahead to page 28 or 50. You'll see the fiscal year '22 reduced resources. The governor requested that agencies with SGF monies provide a reduced resources budget of 10% for 2022. The agency submitted 9 reduced resources totaling $18.9 million, and that includes $9.9 million SGF. Outlined in the table, you can see that, and then there are descriptions below of the reduced resources that the agency offered. And you can see that in the governor's budget, she added, well, took away $1.1 million from the administration program and offset that through funding through fee funds. And that concludes my presentation. I'm happy to stand for any questions for fiscal year '22 or '21.
Thank you. Committee questions? Representative Ballard.
Thank you, Mr. Chairman. I am looking under the enhancements for 2022, and I'm looking at the local health departments. And I'm trying to find where they're listed here.
It's on page 49, the second paragraph down,
Okay.
49, or I guess that would be 27.
I got it. Thank you. I have a little concern with that, but I think Mr. Chairman would tell me I probably should wait and save it for the agency, so I realize I really should, because, yeah, I'll just wait and do it for agencies. Thank you.
Committee, further questions? Representative Helmer.
So in the governor's recommendation, she allotted, or she provided money to fund Medicaid expansion. So 19 million of that would come from the state general fund. And then Medicaid expansion has a separate federal match. So whereas general Medicaid is matched at roughly a 60-40, 60% paid by the federal government, 40% paid by the state, Medicaid expansion is funded at 90% paid for by the federal government, 10% paid for by the state. So the amount of, those are the 596 million that you see there is what we would draw down from the federal government to fund Medicaid expansion. That would cover, I believe, adults up to 138% of the federal poverty line. Currently, childless adults do not qualify for Medicaid.
How I look at that, and just, I have to simplify things, it's a placeholder. That money is holding the place if we would happen to approve Medicaid expansion. Megan, I just have a quick question. When I report out, am I going to use the pages out of this book? Or am I going to use my normal pages that I get?
That's a good question. I would assume out of the notebook, because that's the combined copy with all of the budget analysis. These are just the analyses for our committee, but I will make sure you know.
These are just for our committee?
Those are just the budgets being heard in our committee, but it's part of a larger document that holds all the budget analyses.
I guess my question is, when I go report out, I tell them, you know, KDHE budget starts in their budget books
Right.
on page whatever.
Volume 1, 2,
Yeah, you know, and so I just don't want them scrambling around there trying to find what I'm talking about.
Right. I will get to the bottom of that and make sure that I know.
I've never seen these before. Is this new?
I believe last year was in a 3-ring binder.
Yeah, well,
And
that's
this
what I mean,
is,
but I've never seen anything just printed like this.
right, it's,
Regular budget book, like Megan has there.
yeah, I believe this is this year's equivalent of the 3-ring binder.
Okay. Oh, really? Okay. I don't necessarily care as long as it's the same information, and when I tell them in committee that I want them to start on page 300, I want it to be the same 300 that I'm talking about.
Yeah.
So we'll figure that out. We've got plenty of time. Very good. Committee, further questions?
It's that one. I'll follow up on that, because the whole time we were looking at this, I kept thinking, gee, is this going to be in volume 1, volume 2, or volume 3? Because we have volume notebooks, and I think 2 is our smallest one, but then they give you an index and tell you what page it's on, and I was just trying to think, how are they going to mop up to 47 unless they put it back on this? So you asked the question, I was thinking, because I was going to let you answer it. Even though I'll be sitting there next to you, I go, Yeah, good idea.
Hard to teach an old dog new tricks sometimes. Committee, further questions for Megan in research? Very good, thank you.
You're welcome.
Thank you.
Very nice. Megan.
Okay, next we have Ashley. Ashley, are you on?
Good afternoon, Chairman. I am here. Can you hear me?
Very good, yes, we can.
All right. So do you guys have our presentation? Do you have the slides in front of you?
I know it was sent out by Francie.
Is this health and environment? Yeah. I have this one.
All right, are you ready?
Yes, go ahead.
All right. So good afternoon, Chairman and Committee. I am Ashley Goss, the Deputy Secretary for the Kansas Department of Health and Environment, and I'm the Deputy Secretary for Public Health. I will be covering the first few slides as Dr. Norman is at a press conference currently. So I'm covering his section and mine, and then our Medicaid Director, Sarah Fertig, will do her part, followed up by Mark Heim and Dan Timish, our CFOs, respectively, for Public Health and for Medicaid. So on our first slide, it just gives you a brief description of what our mission and vision is for the Kansas Department of Health and Environment. Our agency vision has not changed. It's healthy Kansans living in a safe and sustainable environment. And our agency mission has not changed either. It remains to protect and improve the health and environment of all Kansans. KDHE is made up of 3 divisions, 2 of which you'll hear from today. The Division of Public Health, the Division of Environment, and the Division of Healthcare Finance. And supporting those 3 divisions is the Office of Administration, which is made up of the Office of the Secretary, our Legal Services Department, our Management and Budget, Office of Information Technology, Human Resources, and Communications. On slide 5, you will see our agency priorities. These remain unchanged from last year. As I'm sure you're aware, our agency is unique for the state of Kansas. Within the United States, we're the only state agency that has all 3 divisions under one roof. And we all have the same priorities, and it's all about our staff and maintaining that we have the appropriate manpower and the ability to recruit and maintain that staff. Without our staff, we would be nowhere, especially during this time of COVID. On the next page, again, this is something that's done annually by the American Health Rankings. This gives you a look into five groups that you can see broken down here, and it has Kansas and where we rank. I do want to tell you that American Health Rankings did not give overall rankings for states this year because of COVID-19, but I do have individual data that I'm going to share with you here momentarily. But as you can see, Kansas is either average or in clinical care, we rank below average, unfortunately. So a little bit of background for this ranking system. America's Health Rankings has published an annual report for the last 31 years. The report highlights 74 measures of population health, covering social and economic factors, physical environment, clinical care, behaviors, and health outcome data. And all of this information comes from 20 publicly available data sources. So as you can see in the behavior category, that one is listed first, Kansas is ranked 26. In this category, the factors that they look at are sleep health, nutrition and physical health, sexual health, as well as tobacco use. Followed by physical environment. Again, Kansas is ranked 35th, and the physical environment category includes air and water quality, climate change, housing and transit. In the social and economic factors category, those that look at community and family safety, economic resources, education, social support, and engagement. Following up with the clinical care category, that includes access to care with preventative clinical services and quality of care. And finally, the outcomes category includes the following factors: behavioral health, mortality, and physical health. So some of the strengths that they identified for Kansas is a strength that we have is low prevalence of severe housing problems and low prevalence of low birth weight. Some of the challenges they identified for Kansas: high prevalence of household and food insecurity, low prevalence of exercise, and unfortunately, the high prevalence of obesity. Highlights in this year's reports, there's 6 of them. The first one, occupational fatalities has decreased. So from 1990 to 2018, we went from 11.5 to 5.5 deaths per 100,000 workers. So we've seen a significant decrease there. High-speed internet has increased. Between 2015 and 2018, we went from 81.4% to 88.4% of all households. The HPV immunization increase. So this is a human papillomavirus vaccine, which is given to both male and females. We saw an increase in the uptake of that vaccine. From 2017 to 2019, it went from 34.4% all the way up to 49.5%. This is given in adolescents between the ages of 13 and 17. This one is not so good for Kansas. We've seen a significant increase in chlamydia. Between 2007 and 2018, we went from 294 cases per 100,000 to 488 cases per 100,000. Frequent physical distress increase. From 2015 to 2019, we saw that climb from 10% to 11.6. I'd be interested to see what it is now with COVID. And suicide, unfortunately, we have seen that go up a little bit as well. We saw from 2009 to 2018 a pretty significant increase from 13.8% to 19.5 deaths per 100,000 population.
Actually, just for a second here, is that deal that you're reading off of, is that like a book?
No, it's just my slide presentation.
So what page are you on then? I lost you at page 6 and.
Is that right? Yeah, so we're getting ready. You were right, Chairman, we were on page 6. I just have notes on my slides that you don't have notes to.
Well, could you get us that kind of stuff?
Yeah,
You
definitely.
know, I'm a visual individual. You can talk all day long. I won't even remember by the time I get out of this room what you've said. But if you could get us that information, that would be very helpful, that we could see it for, at least for myself. Thank you.
Certainly. Yep, Liz will send it over so that you guys have all my talking points as well. So we're going to talk briefly about the Division of Public Health. So now I'm going to start on slide 8. And again, Chairman, I have talking points on this one that elaborate into what you're seeing on your slides. If you guys would like to see those, we can share them as well. So the first thing we want to talk about is our newborn screening program, or NBS is what we refer to it as. You guys will hear more about it as there is a bill that is floating around regarding this program. So on January 2nd, our newborn screening program added 2 lysosomal storage disorders, otherwise known as LSD, to the blood spot screening panel, Pompe disease and MPS 1, with one small blood sample on a card. 32 life-altering and life-threatening genetic metabolic disorders will be detected. These are completely undetectable at birth without the screening. Over 36,000 Kansas babies receive the newborn screening shortly after birth each year. And some of you may remember us talking about these in committee last year. We brought these forward so that you'd be aware that we were adding these. These were a pretty significant increase for Kansas, as we had been behind the nation in what we were screening for. LSDs are a group of diseases that prevent some cells from breaking down fats and sugars, resulting in a buildup inside the cells, causing them to swell. Left untreated, this buildup causes tissue damage and can result in a variety of symptoms. These symptoms are not usually visible at birth, but newborn screening for these conditions leads to early diagnosis and treatment, identifying them before the condition can cause permanent disability and supporting better outcomes overall. Pompe has an incident rate of 1 in 40,000, while MPS has an incident rate of 1 in 100,000. So we're currently screening for those. Both of these conditions were added to the federal recommended uniform screening panel for newborn screening in 2016. So Kansas has just gotten these added, though it's been recommended for several years now. With this change, we are now, as a state, screening for 34 of the 35 recommended conditions, including hearing and critical congenital heart defects, which are point-of-care tests. There's one condition left that we're not screening for, and it is the XALD, and I will mess this name up, but it's X-linked adrenoleukodystrophy. It's a genetic disease that affects the nervous system and the adrenal glands. People with this disease often have progressive loss of fatty covering that surrounds the nerves in the brain and spinal cord. According to HRSA, XALD evidence report, the overall U.S. incident of having at least one mutation associated with this, regardless of the sex, is estimated to be about 6 per 100,000 births or 1 per 17,000. So we are working to get this added into our screening, which leads me to the next point. The agency has introduced House Bill 2250 this session. This would increase a cap placed on the fee fund that supports our newborn screening program. This bill would make permanent the changes that were included in the budget last year as a proviso. Permanently increasing the cap through statute from 2.5 million to 5 million is vital to ensuring resources are available to conduct a quality, effective, and efficient newborn screening program. The implementation of Advanced Universal Newborn Screening Program provides newborns with genetic or metabolic conditions, hearing loss, and critical heart defects the best chance at a healthy development. Next are COVID-19 child care grants. The Bureau of Family Health partnered with the Child Care Aware of Kansas to administer a coronavirus relief fund project to assist licensed child care providers with mitigating the spread of COVID-19 through the Child Care Health Consultant Network. Between September and December of 2020, approximately $2.5 million in funding was awarded to 440 home and center-based facilities across the state, reaching nearly 12,000 children in care, and these would be infant through school age kids. The program continues with alternate funded sources. COVID-19 phone bank. I'm sure many of you are aware that we set a phone bank up in March of 2020 to handle questions about COVID, and now it's handling lots of questions about the vaccine. We've handled 23,289 emails since we had our inbox created in March of 2020. And we've handled 28,442 phone calls since the public hotline was established. State Unintentional Drug Overdose Reporting System, or SUDORS for short. KDHE collects and abstracts data from death certificates, autopsy reports, toxicology findings, and law enforcement reports through the SUDORS program to present a holistic overview of the drug overdose problem in Kansas. The more than 200 data points collected through SUDORS work have been instrumental in driving prevention efforts across the state to combat the opioid pandemic. Do you have questions about any of those?
Any questions? Nope. Move on.
Okay, and last but not least, on the next slide, on slide number 9, these are the 6 divisions that fall in the Division of Public Health. Our Community Health Systems Division, our Epidemiology and Public Health Informatics, Health Promotion, Disease Control and Prevention, Family Health, and our Bureau of Oral Health. On page 10, you'll find what you've heard previously from Megan regarding the enhancements in our reduced resources. For 21 and 22, the enhancements of $150,000 for our trauma program, and then reduced resources you can see there listed below as well. And with that, that's all I have for the Division of Public Health. If you would like me to answer questions, I certainly can, or turn it over to Sarah.
Any questions on the Division of Health? Seeing none, move on to Healthcare Finance.
Thank you, Mr. Chairman. This is Mark Heim with the Division of Healthcare Finance, and I'm kind of cutting in here because I'm actually going to do the presentation for Healthcare Finance. Sarah is on with us today and certainly is happy to take questions or answer questions that you might have for me or for our program, but I will be beginning our presentation with slide 11. So actually, that's kind of just the intro slide. So I'll move on to slide 12. And this is a page where we are pointing out some accomplishments. There are several bullet points there. The first one is COVID related, talks about some things we quickly implemented, and that was KDHE working with KDADs within the medical assistance program. When the pandemic came about, and this allowed our beneficiaries to continue receiving needed services. And of course, while that was ongoing, we were, staying within our federal requirements. Probably one of the main things you'd be interested in is that telehealth was a very hot topic, and that was something we were able to implement, allow people to receive services through telehealth, and was a successful venture. The second bullet point, some of you will be familiar with this. You've heard about it probably for a while, actually, but our newest MCO is Aetna, and they were on a corrective action plan for a while, but as of this past summer, back in June, they were able to complete the requirements for that corrective action plan. So happy to have them moving forward and have that one taken care of. The third bullet point speaks to our CanCare clearinghouse, and the contract that we had was with Maximus. That has been transitioned to a new vendor called Conduit, and that became effective in January of 2021. And happy to say that for the division, that went pretty well, actually very well, given that we were delayed and dealing again with COVID challenges. So but that one is complete as well. The fourth bullet point on the PIL, or the protected income limit, was increased from 747 to 1177, and that helps reduce client obligation. And an update on that one, the regulations setting the PIL at 150% of SSI actually became effective last month on January 1st. So that one is complete as well. And then the last bullet point there, just comment that the application backlog issues have been eliminated. So happy to be able to report that to you. So flipping to slide, the next slide, which is 13. And Ashley kind of mentioned data in her presentation, and data is certainly huge for us. You know, you hear it's a data-driven world, and that's certainly true in our division here with Medicaid. We do have if you're familiar, maybe you've heard the acronym MMIS, which is our Medicaid Management Information System. We do have some major renovations and a modernization project going on with that system. And those improvements are scheduled to go live in January of 2022. So just about a year from now. Flipping to the next slide on page 14. So, you know, Megan gave the overview of the agency budget for public health and healthcare finance. Certainly, you know, we've titled this slide the budget driver, and certainly the big budget driver for us is the caseload. And you've heard a little bit about that today. This slide kind of points out caseload, but also the process that's involved in the caseload. Some of you I know are familiar with it, but kind of walking through the bullet points here. So the caseload budget reflects our program funding needs for the current year and the out year. That budget is determined by an estimating group, and that involves not only us, but KDADS, Children and Families, Department of Children and Family, Legislative Research, Megan's a part of that, and Division of Budget. And we have what we call a spring caseload and a fall caseload. So the spring caseload happens in April each year, and the fall caseload is conducted in October of each year. So actually we're beginning talks about the spring caseload now. So it is a fairly involved process and involves quite a few different people. The forecast that we come up with, the main things that'll come into play, and you can see on that slide, the population and the membership shifts. So, you know, as a consensus group, what are we seeing? What are the trends? You know, are we seeing population increases in a certain category? And those are the kinds of things that we're looking at and talking about. And then program updates have an impact. And one that I think of from last year that may, again, sound familiar to some of you, we were able to, the legislature appropriated some money for some dental policy and added some dental codes. And so that's an example of a policy that has an impact on our caseload. And then, of course, another thing you've heard quite a bit about today already, any fluctuations in the federal FMAP. And just as Megan kind of talked about this, but yeah, if I would simplify it by saying if we weren't in the COVID environment that we are, our FMAP would be right at about just over 59%, or as Megan said, we kind of think of it as a 60-40 split. Given that we are in COVID and the federal government's increased that 59% by 6.2. So the federal share right now is just over 65%. Flipping to slide 15. This one just expenditures versus population. So kind of a snapshot of, you know, again, there are a lot of money involved in caseload, both state and federal dollars. So this one just shows you, where the populations are, whether it be, children, parents, and then where's the bulk of the dollars spent. So as on this one, we point out that, for example, the children and parents make up roughly 74% of the medical assistance population, but account for just over 30% of the expenditures. So just kind of the graph there showing each population and then the expenditures involved with that population. And flipping pages. So this kind of relates to that last slide, the population trends. Again, the last slide showed 74% of enrolled beneficiaries last fiscal year were in the children and family groups. But the expenditures for those categories, again, was just about around 30%. One thing I'll point out here, we note that any point in time during state fiscal year 20, so last fiscal year, the average enrollment of this group was right around 300,000, just shy of 300,000. So this chart, of course, it's a kind of a 6-year running the actuals. So it does not have 2021. And just a comment here, if you were to look at our most recent reports or what we call our Medicaid assistant reports, there are now about 460,000 Kansans who are receiving medical benefits through the CanCare program. So obviously next year, this chart will add 2021 and the numbers are going to look different when they do here. But again, the numbers are up right now. That's so the MOE is the maintenance of effort, what we're required to do to receive that additional 6.2% FMAP for the public health emergency. People are staying on the Medicaid rolls as part of our requirements. And then the next slide, again, touches on the FMAP. So this kind of a busy slide. There's a lot of numbers and information on this one. Megan did a great job of covering the FMAP and explaining that there are different categories of the FMAP, but again, maybe on this one, I would draw your attention to kind of there in the middle under federal fiscal year. And the bottom row is federal fiscal year 2021. So that's where we are now, October through September of this current year. And so we're showing this, there's two numbers there. You'll see the FMAP is 59.68 is our base FMAP, but again, add in 6.2%, and we're currently able to draw at the 65.88 for the majority of the Medicaid program. And I will flip to the last slide for my presentation, which is slide 18. And as Ashley spoke about in her presentation, the enhancements, supplements, this is for the Division of Healthcare Finance Division. These would be the couple additional requests that we had. So again, Megan pointed this out. I'll just reiterate that for 2021, we did request a supplemental of $20.9 million for CHIP. And this is because at the federal level, the CHIP matching percentage is going down. So the state's requirement is going up, federal share is going down. And in FY22, it continues to go down. And so in FY22, we have a request of $20.9 million for state general fund for that same reason. And I will point out, I'm sorry, I just kind of caught this, but that should, under FY 2022, we need to add a dollar sign there. That should be $19 million for Medicaid expansion, just to clarify. And that was mentioned also, I know earlier when Megan was giving her overview of that the governor added 19 million for Medicaid expansion in 2022. With that, Mr. Chairman, I'll conclude my remarks. Happy to stand for any questions. And again, our Medicaid director, Sarah Fertig, is on the call with us as well. And so hopefully between she and I, we can answer any questions you might have for the Division of Healthcare Finance. So thank you.
Very good. Thank you. Committee questions. Mark, I just have one just back on the page 16. Remind me how often we require new applications for Medicaid normally when we're not under an emergency.
Representative Carpenter, it's typically annually.
Is that
It's annually.
annually?
Mm-hmm.
Okay, so they reapply and we analyze their situation every year.
That's right.
Is it by the date of application or is it just at the end of the year, or how does that work?
It's based on when their eligibility would be normally set to expire. So, we receive applications throughout the year. So it's 12 months from the date that their last application was approved.
Okay, very good. Any further questions? Representative Ballard.
Thank you, Mr. Chairman. On page 16, I'm looking at, let's see. I think CHIP. When I look at it in terms of FY 2015, where it was 54,000, and then we go across where it goes down further. In 2018, it's still lower. 2019, it goes up, and it's going up again in 2020. Do you know what happened in between, why we had that spike? I mean, why did it go down in 17 and 18? And what's causing it to go up now other than COVID?
Representative Ballard, I'm not sure why there was a dip in FY 2017 and 18. I'd be happy to talk with some of our folks on the eligibility side to see if they have a theory on that. As for 2019 and 2020, I am aware that there were some additional redeterminations of eligibility that were done during that time, and there was a lot more outreach to try and get more kiddos enrolled in CHIP, because frankly, we were a little concerned that the numbers were going down in 2017 and 2018. So, my guess is that some of the outreach efforts helped to improve those numbers in 19 and 20, and as you very correctly note, FY 20 would include some of the period of time that we were continuing to carry kiddos to the federal maintenance of effort requirement through the coronavirus. But I can try and get more specific information for you on that, Representative.
Well, thank you, but I think the fact that it's, I won't say correcting itself, but whatever you're doing is causing it to go up, because I think we know that there are more children out there, but not all of those that are eligible actually apply for this. And even though, I mean, that's free care, they're covered by that. So the fact that they were going down, I remember looking at that thinking that's not good. And especially when so many of them were coming off of like TANF and a combination of the younger children. That's what I was worried about, because I'm still concerned about TANF and how much cash assistance we actually, provide, childcare and the workability and all of that. But the fact that it's going up says that I hope it's a concerted effort to make sure we're covering as many children in Kansas as possible. But thank you very much. I appreciate that.
Along those lines, can you remind us what the qualifications are for CHIPS?
Oh, boy, Mr. Chairman. You had to quiz me, didn't you? I've got our medical assistant standards, and typically it fluctuates a little bit, but typically for CHIP, you can be eligible for that if your household income is in between about 134% of the federal poverty level, all the way up to about 235% of the federal poverty level. So it's much higher than Medicaid eligibility for adults. And then we also have an additional program called M-CHIP, which kind of bridges the gap between Medicaid and CHIP, and that's available for kiddos whose household income is between 113% of the federal poverty level and 133%.
But there's no bottom on that, correct?
No, there's not.
That's what I was trying to, any child under the 138%, and then even up to the 240% is eligible for CHIPS.
That's right.
And so, committee, that's why I get frustrated sometimes when I see newspaper articles about all they have to do is apply. So anyway, very good. Thank you.
That is why when it went down in 2017 and 18, that was alarming too, because, there was no reason why you could not be applying. Yeah, along those lines. So that's why I'm pleased that it's going up. Thank you very much.
Okay, very good. Committee, further questions? Moving on to the financial overview.
Mr. Chair, committee, my name is Dan Kimmich. I'm the Chief Fiscal Officer, and I will cover the next few slides here. Starting on page 20, we have a breakdown. Chairman Carpenter, you said you like visual, and this is very visual, so I'd like to say we planned it that way, but maybe it was just by accident on our part. But breaking down our 21 funding sources, you'll see here that the largest piece of KDHE health funding comes from the federal government, roughly 2/3. Those numbers were boosted this year by the federal funds that Megan talked about that were provided to the agency to support the COVID-19 response. And then the other, basically 1/3 is broken down between all the other funding sources, the largest of which is SGF, which is 21% of our funding. And then fee funds, we've got just below 12% of the funding. So in total, this is a $3.4 billion budget. And what we're looking at here is consistent with what Megan described. This is Division of Public Health, Healthcare Finance, and Admin. On the next slide, again on page 21, again looking at fiscal 2021, this is a breakdown of the same budget, but looking at how we spend the money. So the largest piece, 86%, is aid and assistance. So this would be both Medicaid and CHIP on the healthcare finance side, as well as our aid to local and public health. The next largest piece is salaries and wages, which is $73 billion, or just about 2% of our expenditures. And the next largest one is contractual services. Mark talked a bit about our MMIS system. That would be an example. Key system, Gainwell, who is now our fiscal agent. So these are the contractual expenses for the agency, and then the balance of our expenses fall into commodities and capital outlay. Then on slide 22, basically looking at the same thing now. For fiscal 22, our funding is up about $554 million from the previous year. The biggest piece of that is the Medicaid expansion amounts that you mentioned. Federal funds here, 66%. We don't have the significant amount of federal COVID dollars in 22 as we have in our 21 budget. SGF is 21% of our funding source for fiscal 22, and P funds is about 12.5% of the funding source. Total FY22 budget is just shy of $4 million. And Then on slide 23, looking at FY 22 expenses, largest piece again, as before, aid and assistance, 90% of our budget, followed by contractual services, 7.4%, and salaries and wages, 1.85%. Total budget, again, just shy of 4 million. Flip to page 24. This is a slide we throw in because there's oftentimes questions. Slide 24 is public health only, so it's just looking at the one division of public health. And you'll see here the total amount of SGF in fiscal 21 and 22 is right in the $25 million range. When we break that out between the SGF match versus non-match, see in fiscal 21, our SGF that is dedicated towards matching grants, which pulls down federal dollars, is 8.3 million. And that 8.3 million this year will pull down about $30 million in federal funds. So it's roughly about 3.6x in terms of the amount of federal dollars we're able to pull down by leveraging our state general funding. That number drops a bit in FY22 to 7.8 million, and it's pulling down about 29 million federal funds, or 3.8 times the amount of SGF. And then the next line is really looking at our non-match. There's a footnote there, number one. The biggest piece of our non-match is the state's investment in primary care, or our community-based primary care clinics. And then aid to local, we talked earlier about the state formula for local health departments. That's, I believe it's about 2.2 million, tiny K, MOE, and then all other. Flipping down to the next page, just because of the significance of the federal funding for the COVID-19 response this year, we wanted to provide a little bit of content to help you understand the amount of COVID funds that we have received as an agency. And there's a list here. If you look at the left side, these are CRF dollars, which are our COVID relief funds. These were part of the CARES Act, recommended by the Sparks Committee to the State Finance Council and awarded by the State Finance Council to KDHE. You'll see that there's $128.3 million there in total, and these listings are the round 2 and round 3 Sparks projects that were funded. There is some supplemental detail that Megan had requested that we provide, which it's very specific and detailed on every one of these. It shows not only the amounts of the awards, but what we've spent, what we included in the budget, what's encumbered, what's remaining, et cetera. So if you'd like that level of detail, I believe that's available through Megan, but this is more high level. The right-hand side of the page starts off with our public health emergency grants that didn't come through the CARES Act or the State Finance Council, but were rather directly awarded to the agency by our federal partners. And the total we're at right now today is $314 million. This is primarily coming from HRSA, CDC, and Health and Human Services. So last year, our public health grants totaled $110.5 million, and so far this year, I believe it was through the end of January, we have been awarded $203 million related to COVID. And we expect that there is going to be more of that kind of money coming our way under the Biden administration. But this is what we know about and what's been awarded today. And then the next couple lines there to the right, we talk about the 6.2% enhanced FMAP related to the public health emergency that Mark was referring to. And these are the amounts that have been reported to the Recovery Office for both fiscal 20 and 21 related to the Medicaid program and to CHIP. I will say overall that the agency, like all agencies that received COVID-19 federal support, does a significant amount of reporting to the Recovery Office on a monthly and quarterly basis on all of these amounts. I think they're doing a fantastic job of aggregating that as a state level to provide to the federal Treasury and OIG to fulfill all the reporting requirements, of which there are many. that is the last slide I believe that we have in our deck, so we will stand for any questions.
Any questions? Representative Ballard.
Thank you, Mr. Chairman. I just want to verify something. I was looking under the Children's Health Insurance Program, since I had asked about CHIP before, where with 20 and 21, we have over, well, almost 8 million. Then if I look under CHIP, 19, and MCHIP, it's 2.2 million. So that allocation from Sparks, that's additional money, or is it funding a specific population within CHIP?
This is Mark with Healthcare Finance. Let me see if I can answer it this way. So under Spark, that amount you're looking at there, we were awarded that. So as for the with COVID, the public health emergency, we kept on the population of kids who were aging out. So once they turn 19, they age out. And we requested funding to keep that population on through through this public health emergency. And so that was an amount we requested, and we were given to keep that specific population on. So you notice it says CHIP 19 / MCHIP 19. The 19 stands for, 19 aging out. Sorry, that's a long answer. I hope that.
No, but that explains it, because I figured it would have, man. The reason why I was asking that, because when I was looking at the other, I could see that it was close to 8 million, but then I wanted specific, because I wasn't sure what the 19 was at age. And then I thought it wasn't year, but then I wasn't sure, so that's why I asked. So actually, for those that we have in foster care, because at 18, they age out, is what I heard you say. So in this case, this was allowing additional money that we could still provide, even though they were over 18. That's what you said. Am I correct?
Yes, and I'll ask Sarah to help me out if I'm.
Sure.
Anything else there I should add that's helpful?
Sure. Thank you, Mark. Representative Ballard. So that funding, when the federal Families First Coronavirus Response Act was first passed in March of earlier this year, it contained in it a requirement that states not discontinue anyone from eligibility for Medicaid programs in order to receive that increased 6.2% increased FMAP. And when that bill first rolled out, it was KDHE's interpretation that included CHIP kiddos as well. We found out a couple months later, I think it was in July, maybe, it was several months later, that CMS did not interpret it that way. And so they told us that we couldn't use federal funding to pay for that coverage. So we were able to use Spark money to cover that instead, since we've been unable to draw down federal funds for that.
Well, I appreciate that, because I hadn't seen that before. And the other thing is, we have had an ongoing discussion about, even when our children age out at 18, they're still, if they were in foster care, were wards of the court. So they don't have family, they don't have anyone else to help them. And, along the line, that is how we ended up getting, community care for education and everything else. So that was good. And I'm glad we had the money that we were able to do that, because then that's that population out there that wouldn't have any kind of coverage from COVID. They're on their own, and most of them are either on the street because they may not have any other place to live, or a whole combination. So whoever followed that, I'm really thankful, because that's once they age out, they're almost like a forgotten population that still needs help, because when my son went to college, if he hadn't had a mom and a dad or someone to help him, he would have had a very difficult time. So I think once they're wards of the courts, we're still responsible for these people to a certain degree. So thank you.
Any further questions? Just one more there, on the chips there, that's the revenue from the increase, the 4.3 chips.
Yes, that's
FMAP.
correct, isn't it, Mark? Yeah.
Yeah, you're looking at the right-hand side of the page, yes. Yeah.
Right, that's what I thought. Okay, how large of a book is the, public health, I guess that's public health grants? What are the qualifications for those? How can that money be spent?
Yeah, this is Dan Timichel. I think we would probably, it's been pretty clear that the monies have to be spent specifically on COVID response-related activities up until now, and that applies to both CARES funding as well as to the direct grants. Now, the nature of each of these direct grants, of course, is different depending upon, the terms and conditions of the grant. KDHE completes a work plan and a budget which gets submitted federally to our partners. So it probably is going to vary, Chairman Carpenter, by grant, but these are all specific to COVID-19 responses.
Very good. I'd just like a little more information on that.
Yes, and I will tell you that the aforementioned report that was requested by Megan, which we provided, it does list out every grant, both the CRF as well as these non-CRF direct awards. And one of the things that was on Megan's template that she wanted us to populate was general use of funding.
Very
So
good. Well, that probably will take care of it then. Okay.
Yeah, that information can be found on that report from Megan where we
Very good.
provided.
Any further questions? Okay, that concludes our KDHE hearing today. Thank you, everybody, for being here. And tomorrow we'll do public hearing on KDHE's budget. All right, thank you.